So let's transition to stage 4 disease. And we were talking before the panel, and I said, what we've accomplished over the past year or so is to take all the standard first-line regimens that we have in this disease that don't have driver mutations in the standard second-line treatment, which was immunotherapy, and just kind of put them together. And I'm going to ask Jariska to review the non-squamous set of trials and just kind of tell us how that's changed the standard of care. Then I'll ask Heather to talk about the squamous subset.
Yeah, so this really has been what I was saying earlier was an avalanche of data for all of us to try to sort of assimilate. And I think there's been pearls of wisdom that we can take from each of the major studies. I think the main thing that's different in 2019 or has come out of the last year is chemotherapy alone is not enough as a first-line treatment for lung cancer. Immunotherapy is going to be part of our treatment paradigm, and PD-L1 has helped us in some way to sift through how we should be thinking about these patients. So right now, it would be our practice to do a PD-L1 2,2-C3 assay in patients who are high expressors of greater than 50%. We would advocate for single-agent pembrolizumab based on KEYNOTE-024, and in some ways supported by KEYNOTE-042, even though that wasn't the remit of that particular study. So KEYNOTE-024 has this now unprecedented survival of 30 months. There was an updated overall survival output from World Lung. So I would consider that certainly a new standard of care. The other compelling data is KEYNOTE-189, which is the combination of platinum pemetrexed with pembrolizumab. And that showed a benefit in both progression-free survival and overall survival across all PD-L1 strata, and with a hazard ratio of 0.49 for all comers in patients who got the triplet combination compared to chemotherapy, which is really something we haven't seen in a non-oncogene addicted group, such an impressive hazard ratio. And then sitting next to you, I couldn't possibly not mention Empower 150. So that's another option, I think, for us.
You so long.
Yeah. Started to get a move on. So that is a very complicated study, a 3-arm study, looking at the primary endpoint was Arm B versus Arm C, which is the 4-drug combination of platinum taxane, atezolizumab, and bevacizumab, with the control arm ECOG 4599, platinum taxane, and bevacizumab, and that did show both a progression-free and an overall survival benefit. I think what was really interesting about that data was that there was some enrollment of the EGFR and ALK population and showed a benefit in that population, and then a patient with liver metastases, which I think was based on the data in ECOG 4599, which also showed a benefit in that group. So I think this is compelling, and probably that is the EGFR ALK may be the niche where that is used. The other 2 studies that I think are important are probably Empower 131, which is, 132, getting the numbers mixed up, so many empowers, and that's platinum pemetrexed with atezolizumab. That showed a PFS benefit, no overall survival benefit. And then lastly, Empower 130, which is a somewhat unusual chemotherapy backbone, platinum and nab-paclitaxel with a maintenance of either supportive care or pemetrexed, and then the investigational arm adding atezo to that. And that showed both a PFS and an OS benefit, and I think is being submitted now for regulatory consideration.
So in the squamous patients who are not having a driver mutation, which is going to be the majority of them, but important to know who they are. We had a couple of trials that were presented at ASCO in 2018, both with the same idea of carboplatin taxane, and one of them it was taxane either being paclitaxel or nab-paclitaxel, one just being the nab-paclitaxel, and then either with or without pembrolizumab or with or without atezolizumab. And they both showed a good PFS benefit, but more so with the pembrolizumab trial than with the atezolizumab study. The pembrolizumab study also had an overall survival benefit. And so that actually has become a regimen that I don't see a whole lot of squamous patients, but I do have a couple. And we've started now with carboplatin, and I usually just use paclitaxel to start with, unless there's been some sort of a sensitivity reaction, and then I'll switch to the nab-paclitaxel, and then adding in the pembrolizumab. But the atezolizumab data is still maturing. There was a lot of discussion around how do we break these subsets down and look at their PD-L1 levels and various subsets, and does that change outcomes? And I wasn't overly convinced by that, but I still think that just as we do in non-squams and squams as well, there still are patients who are benefiting more than others. When you're doing the chemotherapy combinations, more are benefiting more, and therefore I'm not using PD-L1 as necessarily an exclusion, but there are patients who maybe aren't benefiting as much, and I think we need to be still exploring that and not just have it be everybody gets the same thing. One of the things we haven't really talked about yet, but I'm sure we're getting to, is this idea of who should not get immune therapy. And there definitely are patients from a toxicity standpoint who should not be getting these drugs, and those are patients who are already having very active autoimmune diseases. Even though it's very rare outside of academic settings, the patients who have had organ transplants, and some debate over, well, if it's a kidney transplant, is that different than others? But I think we need to make sure that that's part of the education that everyone's hearing, is it can't just be reflex. You have to stop and really make sure that you understand the patient's history, and that there isn't some lurking serious autoimmune thing that they forgot to talk to you about.